I'm going to deal with the topic diagnostic considerations in cervical spondylosis. I think there are many other speakers, so we will try and stick to our own topic, so I will not be dealing with anything other than this particular aspect, because there are people who are going to be talking on the treatment aspect and the Ayurvedic considerations. I'm basically trying to focus my entire talk on understanding cervical spondylosis as well as on the diagnostic aspects related to cervical spondylosis. The incidence. Cervical spondylosis is basically a problem of the vertebral column. The vertebral column and its contents and surrounding structures are responsible for some of the most common afflictions of man. Neck and or back pain originating from these structures affect almost every individual at some time in life, and every year about 4% of the population suffers from an episode. So that gives us an idea of what sort of an incidence we have. It's one of the most prevalent problems for which people come to a clinic. And this disorder ranks next to alcoholism as the leading cause of time lost from work worldwide. So as we know, most of the people who are on a sedentary lifestyle today, especially, we have more people sitting on a computer and working from an office environment. And even because of that, probably, this is becoming the second most prevalent problem, resulting in loss of work time. So after alcoholism, I don't think that is the situation in India, but worldwide alcoholism is the single largest cause of time lost from work. And next to that comes problems relating to the neck and the vertebral column. It's not only the neck, this includes the back as well. So neck and back pain together account for such a high incidence. To understand cervical spondylosis, we very commonly use the word cervical spondylosis in a very broad sense. So we generally tend to speak about anything relating to the neck, any pain or discomfort relating to the neck, shoulder, hands, etc. We commonly tend to call all that as cervical spondylosis. But technically speaking, cervical spondylosis is a term applied to a chronic degenerative disease of the intervertebral discs of the cervical vertebrae, and it is associated with reactive changes in the adjacent vertebral bodies. So the real pathology, to get a diagnosis of cervical spondylosis, one has to have problems with the intervertebral discs and the surrounding structures, and more particularly to the vertebral bodies. Symptoms are manifested and produced not by these structures. Most often the symptoms and clinical presentations of what we see in cervical spondylosis are not produced from the disc at all. But because of the disc, other structures are affected. Other structures like the facet joints, the nerves which are emerging from the spine are the ones which are the cause for the pain, and the muscles which are surrounding the vertebrae, that is the paravertebral muscles and so on, are the sites of pain and sites where the symptoms are manifest. But the problem per se is originating or is limited to the intervertebral discs and to the adjacent vertebral bodies. So that's the technical clear definition of cervical spondylosis. There is also this confusion very often about calling this a cervical spondylitis, whereas we all know that it is a degenerative problem, and hence the more appropriate term to be used is cervical spondylosis and not cervical spondylitis. Very often, very rarely do you get a condition of an inflammation of the cervical vertebrae, and only in that instance are we supposed to call it a cervical spondylitis. What we often encounter is only the degenerative problem, and that is to be called a cervical spondylosis. A look at the anatomy of the cervical spine, I think, is in place when we are to understand cervical spondylosis totally. We know that the cervical vertebrae comprise of the 7 bones, 7 cervical vertebrae, the first and second being the atlas and the axis. Then we have cervical vertebrae 3 to 7, all arranged one on top of the other with a typical lordosis. As we can see here at the cervical region, we have a lordosis. Are you able to see the pointer from that side? When I am pointing, is it visible from that side? Okay. So the cervical region has got a lordosis posteriorly. Then we have the thoracic vertebrae, which is having a bend like this, and then we have the lumbar vertebrae again with another lordosis here. So that's the typical arrangement of the cervical vertebrae. We know that the cervical vertebrae enclose a spinal canal. I'll show the other pictures of the individual vertebrae. So now we see the atlas, the axis, and the other vertebrae. They all enclose a spinal canal. They all have a body here, and then that is the spinal canal with these laminar processes, and that is the spinous process which is jutting posteriorly. So what we can palpate from the back is the spinous process that is centrally located, and to the sides we have the laminae, and here we have the notch. This is the facet joint where one vertebra, if you look at this is the facet joint here, and the vertebra on top articulates with the vertebra at the bottom along this facet joint. We are able to see this white color structure is the intervertebral disc. This structure is the bone, and between the two bones it is a cartilaginous sort of structure, and this as well as this represent the intervertebral discs, which are the real site of the problem. And we see here that it encloses a spinal canal, and the nerve roots, you can see a groove along the side through which the spinal nerves which are emerging between the vertebrae come out of the spinal canal. So we have got the two very significant structures which are very closely associated with this vertebra. One is the spinal cord which passes through the spinal canal. Now we are seeing a transverse section here, as if we are looking at it from above. So we can actually have the spinal cord coming in through the vertebra, through the spinal canal, through this area, and the emerging nerve roots are coming out through this small notch which you can see on the sides. The atlas and axis are special bones in the cervical region, specifically because that is what permits the whole range of motion. That's the most mobile bone in the cervical, in the whole vertebra, because that's the area where we have the whole range of lateral rotation. All the other vertebrae are highly limited in their movement, in their ability to give us motion. Most vertebrae are only capable of some lateral rotation as well as a slight level of flexion and extension. Whereas this is the one area where we have got the pivotal joint, which enables us to have a total about 180, close to 180, about 140 degrees of lateral rotation is possible only because of this pivotal joint between the atlas and the axis. All the other vertebrae are almost typically of this sort of an arrangement of a central canal. This is the vertebral body, the transverse processes, the spinous process, and the intervertebral disc. So the appreciation of this anatomy will help us to understand the disease a little bit better. See, here we are able to see one vertebra aligned on top of the other, and as I said earlier, this is the facetal joint along which the movement is permitted. So the vertebral body lies anteriorly and the spinous process lies posteriorly. The facetal joint is here. Even the osteoarthritic changes of this vertebral joint is also part of the cervical spondylotic syndrome. And very often what we see, very often in our clinical practice, we also tend to come across inflammatory conditions of the neck, which is actually an extension of rheumatoid arthritis or other inflammatory joint related problems. They are manifested in this facetal joint and which can very closely resemble cervical spondylosis. Very often that's where our diagnostically we can go wrong, and in that sense the typical treatment for cervical spondylosis will be counterproductive. Our concept of ama nirama, when we see that there is a ama anubandha, it is often a condition where it is an arthrosis, it's an arthritis of this joint rather than the typical cervical spondylosis or the degenerative condition in the intervertebral disc. The yellow structures that we are able to see are actually the spinal nerves emerging from the spine outward. These actually come out from the spinal cord and then innervate the specific areas of the body which are called as the dermatomes or the myotomes. So there are both the motor nerves as well as the sensory nerves going towards the spinal cord, and the motor nerves emerging from the spinal cord. Both come out through this, and they get the sensory nerve has got its the ganglion outside the spinal cord, whereas the motor nerve has got its final ganglion within the spinal cord, and from there it is only the extension, the axons are coming out in the form of the nerve, whereas in the case of the sensory nerve, the ganglion itself is lying outside the vertebral column, and the postganglionic fibers enter into the spinal cord in the form of the sensory nerve that is coming here. So these are the spinal nerves that we see, whereas the spinal cord is situated within this. There is actually basically a lot of extra room. The spinal cord doesn't occupy the entire space of the spinal canal. There is enough room to allow for degeneration, because basically the space reduction in the spinal canal and these two notches are the reasons for most of the symptoms that we see in cervical spondylosis. So to actually anticipate that, the body has provided for a lot of extra room, because the spinal cord really doesn't occupy the entire spinal canal. So even in spite of a lot of reduction in the size of the cervical canal, of the spinal canal, still there is room for a person to be absolutely asymptomatic. But it is when this gap becomes too small that a person starts becoming symptomatic. And that's why very often you can see anybody at a particular age level who is beyond say 60, anybody for whom you can take an X-ray or an MRI, you will invariably find that there is a reduction in the spinal canal diameter. But it may be totally asymptomatic, and so just an MRI should not be the basis of diagnosing something. You can be totally asymptomatic with a lot of problems which are visible on the radiograph. Then this is again a picture here which is maybe a little bit more clear. This is the adolescent axis which is providing for the pivotal joint and the range of movement. So just to explain this a little more in detail, these pictures are here. I think you can interrupt because we have enough time. If you are not really able to get through any particular phase, you please feel free to interrupt. I can explain it in greater detail. So this you are able to see the vertebral body here and the spinal canal, the two transverse processes and the spinous process. This is a cross section of the spinal or the vertebra at this particular level of the thoracic vertebra. Actually, this is not the cervical vertebra, but the thoracic vertebra represents a typical vertebra. So we are able to see how the spinal cord, this structure is the spinal cord. So as you can see, there is a lot of empty space on either side of the spinal cord. And here we are able to see the anterior ramus and the posterior ramus coming out from the spinal cord. They both merge together and come out as the spinal nerve, which is coming out through the groove between the facetal joint and the edge of the vertebral body. So this is the vertebral body, and between two successive vertebral bodies we have the intervertebral disc. So the intervertebral disc actually forms a cushion between the two vertebrae, and on the posterior side of this we have the two facetal joints which permit that motion. So a problem relating to this disc or the articular cartilage of this particular facet joint both tend to impinge on the spinal nerve that is emerging from here. And those two problems are the real cause of clinical presentations in most cases. The vertebral disc here can protrude into the spinal cord and compress it centrally, or it can protrude on the sides and compress the spinal nerve. And these two are the classical reasons for most of the problems which we identify as part of cervical spondylosis. When it is a central bulge, we call it, it produces compression on the spinal cord, and thereby it results in the condition called as cervical myelopathy. Whereas if it bulges on the side, it presses on the spinal nerve, and then it produces the typical symptoms relating to cervical radiculopathy. When it's a central bulge, what is happening is the long cracks. For example, even if it is pressing at C2 or C3 or C6, for example, the symptoms are not manifested in the area of distribution of that particular vertebra. The symptoms will manifest in the lower part of the body because the spinal cord at this point contains the fibers which are emerging much lower. Whereas if the bulge is lateral, it compresses on the specific spinal nerve which is emerging between these two vertebrae, and at that point it produces symptoms pertaining to that particular nerve, and that particular situation is called as cervical radiculopathy. So if you look at what is happening, very often the most cardinal symptom or the most cardinal presentation is pain. Sorry, I think there's some alignment problem in this. Anyway, bear with that. So the main cardinal symptom that we find along with these spinal structures is pain, and pain is not often a very simple phenomenon to understand. There are different types of pain which we need to differentially understand. One is the local pain. A local pain is produced by the irritation of the local nerve ending. For example, it is very important for us to understand that the intervertebral disc does not have local innervation. So the pain that we are feeling at a particular location is not arising from the intervertebral disc, though the problem is basically with the intervertebral disc. That is the plus and the minus point. Number one, the cervical disc is the most vulnerable part of the entire vertebral column, and the cervical disc is continuously getting trauma. With mild jerks that we encounter while on travel, every small jerk is tending to press the intervertebral disc, and that is the structure which starts getting ruptured at the earliest. That we don't tend to detect because we don't have nerve endings in the intervertebral disc. So we don't get a sensation of pain when only the intervertebral disc is undergoing a damage. Whereas when some other structures in the vertebral column undergo damage, the most highly innervated portion is the periosteum, or the covering of the bone. So when the periosteum is rich with nerves and there is a small problem occurring in the vertebral body, that is when we start feeling the pain. That is one of the areas which is very pain sensitive. So pain that is arising out of that local structure, there is an inflammation or a damage that is taking place in a particular structure, and the nerve ending that is present there is picking up the pain, that is called as a local pain. Then we have what is called as a referred pain. For example, one could feel a severe pain in the shoulder, and that could be something totally not related to the shoulder at all. Very often we all know that a person with a cardiac problem refers to a pain in the shoulder and the left arm, isn't it? That is called as a referred pain. The pain is not originating here. That happens because they share a sort of very close region in the brain for pain sensation. So the area of the brain which represents pain from the chest as well as from the arms, left arm, are more or less very close to each other, and so a problem relating to the chest can produce a pain in that area which also shares the same or similar close regions of the brain. This type of pain is known as the referred pain. So if you are actually seeing the pain here and we do a thorough investigation of this region, you don't find any problem because it is actually referred pain from some other area. There are so many other organs from which you get referred pain in the neck as well as in the shoulder joints. One of the common things which could be easily missed out, if you see on the right side a liver problem or a gallbladder problem, very often produces a referred pain in the shoulder. That can easily be missed out. So that we must understand is not a local pain, but it is a referred pain. Then the most commonly encountered pain relating to the cervical region is the muscle pain. Muscles are highly innervated and they are the ones which are constantly in motion. Any sort of specific strain to the muscles can produce pain in the muscle, and very often what we encounter and very often what we misdiagnose as cervical spondylosis is actually the muscular pain associated with the cervical vertebrae. The sort of spondylosis which responds dramatically. 90% of the patients who come to us complain of pain in the neck, and that's the cardinal symptom. Immediately we say it's cervical spondylosis and start treating. It is a manifestation of cervical spondylosis in a very few cases, but very often it is just muscular spasm, which is what mimics cervical spondylosis in most cases. It is just a spasm of the muscle, and that is the one which gets instantaneously relieved. At the clinical level, we get very thrilled with dramatic results. The moment the patient came in and said, we did some oil application or some massage, and we immediately got some fantastic results. And we are extremely happy that I have cured cervical spondylosis with a massage. Very often what we are doing is to relieve muscular spasm, and that is what can produce a dramatic result overnight. Cervical spondylosis is a disease that is occurring over years together, and it's not a disease which can be cured overnight. The relief that we find is purely with reference to the muscular pain. Next we have the radicular pain. The radicular pain is what we typically encounter when somebody is complaining of pain in the arms, weakness in the arms and so on. Especially the pain in the arm is what we call as the radicular pain. Pain in the arm or other areas supplied by the particular nerve that is getting impinged by the cervical spondylosis process. And the pain which results out of that is called as the radicular pain, and is this one of the cardinal features of cervical radiculopathy. Whereas, as I mentioned earlier, if the disc or the surrounding structures are producing a pressure on the spinal cord per se, you don't see any symptom at that level, whereas you see a symptom much lower down and along the long tracks, and if you got widespread manifestations, that particular condition is known as myelopathy, and that type of pain is known as funicular pain. So there are these 5 types of pains that we need to understand with reference to cervical spondylosis. Now we will come to the most common clinical presentation. Cervical spondylosis, the most important presentation is pain or tenderness in the neck, which is what is commonly encountered. Next we see patients presenting with pain and numbness in the shoulders, hands or fingers. Weakness of the muscles of the hand or fingers. So if the motor part of the nerve is compressed and is damaged a little bit more, you first feel weakness in the arms. If the sensory part is lightly affected, then you have the pain, and you may have numbness as well if it is the sensory part. You can have complete loss of sensation also if the compression is very severe. Difficulty and restriction in neck movement is another very important symptom, and that is primarily produced by the muscular spasm. It is a protective mechanism of the body. When there is a damage to the particular area, the body wants to ensure that the problem doesn't go further, and so it produces a muscular spasm which restricts the ability of the neck to move around. And then if the upper regions of the cervical, if the upper vertebrae are involved, that is C2, C3 damages, lead to pain in this part of the head that is called as the occipital headache. That's also a common manifestation in case of upper cervical lesions. And dizziness that is aggravated by jerky neck movements is another common presentation of radiculopathy in patients with cervical spondylosis. So these are the common things that we encounter. Most of the clinical cases are actually presenting with cervical radiculopathy. All these symptoms are pertaining to cervical radiculopathy, and we have a set of uncommon presentations. Cervical myelopathy, which is the compression of the spinal cord, is not as common as cervical radiculopathy. And in myelopathy, we can see the symptoms like this, that is a bladder dysfunction, bowel dysfunction, a tingling sensation in the legs, one can have weakness in the legs, numbness in the legs, and so on. There is a big difference between the weakness and pain, etc. in the legs arising out of lumbar spondylosis and that arising out of cervical spondylosis. It is very, very critical for us to examine and understand that, because in the case of lumbar spondylosis, you are typically seeing a lower motor neuron lesion. If you look at the reflexes, we will find that the reflexes are actually reduced. The deep tendon reflexes like the knee reflex and so on, knee jerk, is typically reduced in the case of lumbar spondylosis leading to pain in the leg, whereas if it is cervical myelopathy, we will find that the reflexes are exaggerated. Very often we can get patients suffering from problems in the lower limb, complaining of weakness, pain, etc., which can be easily missed. I have personally treated a patient who had a foot drop. He presented to a neurology clinic, and he was immediately seen, and they took an MRI of the lumbar spine and found that there was lumbar spondylosis. Immediately they conducted a surgery, decompression of the lumbar disc was done, but the patient did not improve a bit, and somehow he happened to come across, and the moment we examined him, we found that actually he was suffering from an upper motor related issue. Just a knee jerk could show that it was exaggerated reflex, and when we checked his neck, he had severe cervical spondylosis, and once we treated him for his cervical spondylosis, he recovered fully. It was purely a question of diagnosis. There is no magic that was necessary to cure him actually. So he underwent the surgery without any purpose. So it is very important for us to understand that lower limb manifestations could also be a result of cervical compression. So that, but though these presentations are not very common, they are still there. We need to understand that they are there. So now if you look at the majority of the symptoms that we are able to see, excuse me. Why are these symptoms produced? So all these symptoms that we saw about are produced by these particular processes. Number one is the damage to the intervertebral disc. As I said, damage to the intervertebral disc has started much before any of these symptoms are manifesting, and that is something we don't tend to see at the upfront. It is something that is happening in the background. Most of the symptoms that we see, as I said, are basically relating to spasm. The local pain that we have in the neck is relating to the spasm of the paravertebral muscles. The inflammation of the articular joints, when there is an osteoarthrosis in the facet joint, there is also an inflammation which comes on top of that, and that inflammation can result in local neck pain. Damage to the vertebral bodies are also the next very important cause of pain, which is more or less of a persistent nature. In very severe cases of cervical spondylosis, when one goes into serious stages of that, it results in damage to the vertebral body itself. Osteochondrosis occurs in that situation, and that leads to a persistent sort of a pain. And lastly comes, but the clinical manifestation is very large in this area, damage to the spinal cord or the exiting nerve roots. That is what produces typical cervical radiculopathy and myelopathy. So there is a local pain which is basically muscle or the vertebral bone or the facet joint, and the referred pain coming to the upper limb or to the lower limb, which is part of cervical radiculopathy or cervical myelopathy. So these are the causes of all the symptoms that we see as manifestations of cervical spondylosis. Among these symptoms, paravertebral muscular spasm is the most common cause of neck pain, where the damage to the intervertebral disc is the most common structural cause of pain in the neck and related structures. So the paravertebral muscular spasm is not a structural problem, it's only a functional problem. For some time the spasm will be there. With some maneuvers, very easily the spasm is overcome, and after some time you have no abnormality, the patient is perfectly okay. Whereas the most common structural problem is relating to the intervertebral disc. So we said there is the damage to the intervertebral disc is the most cardinal aspect of cervical spondylosis. So I thought it's good for us to have a deeper look as to what is actually causing the pain, what is causing the damage, how the damage is happening, and the stages associated with the damage to the intervertebral disc. Number one is the causes. If you look at the causes, number one is age. Aging produces a lot of changes in the tissue. It's very important for us to note that, just as I said, the intervertebral disc doesn't have direct nerve supply. Similarly, it also doesn't have blood supply. There is no direct vascularity to the intervertebral disc. So the intervertebral disc actually derives its nutrition from the surrounding fluids only. The capsular fluids that are present in the periphery, it actually absorbs nutrients from the extracellular fluids only. There is no direct blood supply to the intervertebral disc. So with age, there is a reduction in the nutrition that is going into the intervertebral disc, and that itself results in changes. There are a lot of premature degenerative changes, and the causes for that are many. Trauma of a mild and repeated nature is the most common cause of the problem. See, when we all recognize, if you ask a patient, do you know of any reason why you developed the problem? Very few of them can say that. Suppose they have had a strain, suddenly they turn somewhere and then got a neck pain, or they had an accident which has resulted in a severe disc prolapse. Those are things the patient can recognize, but very often the real cause is not that one episode alone. Continuously, when a patient has been traveling, there is a lot of repeated vertical compression on the disc, and before that, if the disc has become brittle, with the age, there is a reduction in the water content in the intervertebral disc and it becomes brittle, and with that brittleness and with complete repeated vertical compression of the intervertebral disc, it starts cracking up. And that is the real cause of why suddenly at one point of time the patient develops a very serious episode. An acute episode is actually on top of a chronic problem that has already been there. Whereas some patients who have been absolutely normal with a severe accident can also have a sudden rupture of the intervertebral disc without any particular predisposing factor. Now we will have a detailed look at the intervertebral disc. Intervertebral disc is actually this white structure which is like a cushion between the red structures that you are able to see are the two vertebral bodies, and this white structure is the intervertebral disc. You are able to see that it has got two distinct regions, a central darker region which is known as the nucleus pulposus, and there is a peripheral white region which is known as the annulus fibrosus. The name itself is very clearly depicting what is the nature of that. Nucleus pulposus, as the name suggests itself, is a pulpy material. It's sort of a jelly-like material which is full of glycoproteins, mucopolysaccharides. So it's a carbohydrate-rich structure. It's a jelly-like structure, and it is it's sort of enclosed in layers of fibrous tissue which produces the annulus fibrosus. If you imagine that there are concentric circles of fibrous tissue arranged one concentric to the other and one on top of the other. There are two levels of layers that form the annulus fibrosus. So fibrous tissue that is like this, like a parota. I would typically ask you to imagine about the Kerala parota. You have got layers and layers, one surrounding the other, and there are gaps between those layers. If it is very tightly bound, it is different. If you take the parota, they also do that in the restaurant, 3 or 4 parotas together and they bang it to make it soft. So similarly, when a gap develops between those layers, that is what happens in a degenerated disc. There are layers like this, and from top to bottom there are again layers, which is what you can appreciate. Here you can see the layers that are concentrically arranged because it is a section, whereas there are also layers from top to bottom. So between these layers are tightly packed in young age, and with age they start slowly proliferating. So this is basically fibrous tissue which encompasses the jelly-like tissue. So the jelly is what gives the cushioning effect, and the fiber is what keeps the jelly in place without running away. So the jelly is kept in place by the fibrous tissue. And that is the physical aspect of a normal intervertebral disc, and it has got a particular height. There are a number of disc related problems, and the terminology used to describe them is given here. This disc, as you see, this is a pictorial representation. It's not actually a photograph. So this is a pictorial representation which shows a normal disc, it is just clean and straight. Whereas if you can see some serrated margins between, that is a disc which has started to degenerate. This sort of structure where there is a bulge that is happening from the disc is called as the bulged disc. In general, the disc has totally got elongated. There is a bulge that has taken place along the margins, and that is called as a disc bulge. The next is a situation where you can see the inner jelly has actually come out of the fibrous tissue, and that condition is known as herniated disc. Very often, I think out of common sense, I used to imagine when we used to study that herniated disc, or a disc prolapse, I used to think that the disc will move away from there. The disc is not moving away from there. Disc is there, but only the nucleus pulposus actually bulges through the cracked annulus fibrosus. So the nucleus pulposus is actually bulging out in this situation, that is called as the herniated disc or the disc prolapse. Thinning of the disc is also a very common feature. You can see the height here is high, whereas after some time the disc has become very thin. This is called the thinning of the disc. And here you are able to see that as a more chronic cases, the vertebral body itself has started undergoing changes. This is the lipping that is taking place. So this is a bony change that has taken place in the vertebral body associated with osteochondrosis. So degenerative osteophyte formation is characterized, is a characteristic feature there. You can see that the shape of the vertebra itself has totally undergone a lot of change. Now we will go through, as I said, these are the different stages associated with disc degeneration. The first step that takes place in this degeneration is dehydration of the disc. Snigdhata, when we understand it, very easy for us to understand it from the Ayurvedic perspective. With Vata Kobam, that is with aging, we know that Vata Kobam takes place. What is the characteristic feature of Vata Kobam? Is Rukshava. Snigdhata is coming down. This is the modern explanation of what we have been trying to say. That the hydration, that is the moisture content in the disc is coming down. That is the first stage of degeneration, and that is called as dehydration of the disc. A disc which is dehydrated is highly prone to other forms of degeneration, because you can imagine a rubber, you bend the rubber, what happens? Very flexible. You can compress it, it will come back to its normal shape. Whereas you put the rubber in the sun for a few days, what happens? It loses moisture content. And then you try to bend it, what happens? It will crack. So similar thing is happening to the intervertebral disc. As we begin to dehydrate, then any sort of pressure on the disc starts producing a crack in the disc. And those are the second stage. That is, the tears in the annulus fibrosus forms the second stage of the problem. Once the tears are formed, the pack of the disc becomes loose, and then it starts bulging because the cohesiveness of the disc is lost, and then with the compression taking place, the disc starts bulging. It starts becoming thinner and fatter. That is called the disc bulge stage or the protrusion of the disc. And then as a second stage to that, you can have it cracking up fully and allowing the nucleus pulposus to come out, which is the herniation of the disc. And then you have got the osteophyte formation, and lastly the total delineation between the intervertebral disc and the bone is lost. Tissues are intermingled and it becomes a huge mess, and that stage is called as osteochondrosis. I've got some good pictures to show you on all these. Now we look at the molecular mechanism of disc degeneration. I spoke to you about that. Why is this degeneration taking place, or how is it taking place? Number one is decreased diffusion. As I said, there is no direct blood supply to the intervertebral disc. It is only getting its nutrition through diffusion. So people who do not have adequate physical activity do not have adequate peripheral perfusion. That is, the blood circulation and the extracellular fluid receiving the nutrition is low in people with very poor physical activity. And so the nutrition that is getting diffused into the disc becomes low. Especially with age, the diffusion becomes reduced. And the decreased diffusion is responsible for the preliminary stages of degeneration. And then there is decreased cell viability. We all know that cells are dying and they are getting replaced by new cells. The rate of replenishment of the cell comes down with age. And so tissues, the cells are getting dead, but they are not getting replaced with fresh cells, and that leads to degeneration. Why that is happening? If you look at it from a biochemical perspective, there is a decreased proteoglycan synthesis. Proteoglycans are actually proteins and carbohydrates together. These proteoglycan synthesis comes down with age, and that is also accompanied by alteration in collagen distribution. Collagen is the fiber which holds these proteoglycans together, and that is the matrix which forms the annulus fibrosus. So the collagen distribution comes down, and the level of synthesis of the proteoglycans also comes down, and that leads to lack of strength in the intervertebral disc. That, coupled with the low hydration level of the disc, makes it highly prone to degenerate to tears and other forms of damage. We'll just have a look at some of the pictures to understand this phenomena better. This is an MRI of a young child, a perfectly normal MRI, where you can see the vertebral body. This is the intervertebral disc, very clearly distinguishable central dark region and peripheral white region. You can see that all the discs are perfect in height, color, etc. Whereas if you look at this disc, you are able to see that there is a particular problem here. This is a concentric tear. There is a tear in the annulus fibrosus. Here you are able to see that the nucleus pulposus is actually communicating with the exterior. This is completely torn and it has actually started bulging out. This is a herniation that has taken place in this disc. If you see this disc, there is no structural change that has taken place. You cannot see anything on the MRI like this, but then the distinction between the two is lost. It has become totally dark. This condition is known as dehydration of the disc. If you see in an MRI that the intervertebral disc is also become dark on the T2 weighted images, then we have to diagnose this as a dehydrated disc. And the dehydrated disc, in this particular disc, you are able to see that the annulus fibrosus is breached here and the nucleus pulposus has actually come up to here. This is a tear in the disc. This is a tear, but there is no bulge. You can see the margin is clear, but there is a tear. This patient can very easily get into sort of a prolapsed disc. You are also able to see some minute tears here. These holes in this are actually minute tears, but they are totally asymptomatic at this stage. This patient will not have any symptom. Whereas he is an ideal candidate for a serious disc prolapse. If you just throw him once on the floor, he is going to have a serious disc bulge. This is another MRI. Here you can see that this person has got a dehydrated disc and there is a small tear here, a radial tear which can easily produce but right now he is asymptomatic because there is no bulging of the nucleus pulposus. This also you can see, these are the normal intervertebral discs, but these discs are totally dehydrated. So this is how we diagnose dehydration of the intervertebral disc. This is a picture showing again the degenerative changes where the nucleus pulposus is actually bulged out. These are small tears that have taken place. I would like to describe, there are three types of tears that take place. One is between the two layers, and as I said, there are so many layers laterally arranged or packed one after the other, and if there is a crack between the two layers, it is known as a lateral tear, circumferential tear. That tear really doesn't produce any symptom, because just because the two layers are separated out, the nucleus pulposus is not going to bulge out, so they are asymptomatic. There is another type of tear which takes place in the vertebral plane. There are layers like this. If there is a tear that is happening between the two layers, that is a point of weakness, but that is a chance for a bigger tear, but at that point also it is not symptomatic. But what really produces the symptom is when it tears across like this, from the middle to the side, that is called as a radial tear. If there is a radial tear in the disc, the annulus fibrosus moves apart and the nucleus pulposus bulges out, producing a herniated disc, and that is when somebody is presenting with a symptom. This is a cross section of a spine where you can, of a vertebral area. You can see this white region is the intervertebral disc. This is the spinal cord, and from the spinal cord you are seeing the spine emerging, spinal nerve is emerging out. So up to here, this red, up to this black area is the spinal cord, and spinal cord margin is just extending itself as the spinal nerve. You are able to appreciate there is a bulge of this white tissue to the side. This is a herniated disc. The herniation has taken place laterally and it is compressing on the spinal nerve, and this patient will suffer from radiculopathy on this side of the nerve, and where he is going to suffer from symptoms depends on what nerve this is. The area that is supplied by this nerve is affected by this bulge, by this herniated disc. The same bulge can take place here, in which case if it is a slight bulge there may not be much of a problem because there is a gap between the spinal cord and the intervertebral disc. Whereas if the bulge becomes really large and starts compressing here, that is when it starts producing symptoms. Whereas actually the ganglions are lying only here. There is this epidural tissue and all that. First level it only compresses this stage. So there you can see in an MRI they will talk about subdural compression and so on. At that stage also the symptoms are not, you don't get myelopathy. Whereas if it starts really pressing on the white region here, then it starts manifesting as symptoms manifested in the lower limb. So these are the different levels of problems that are happening with the intervertebral disc. And this is the most serious form of damage, which is the osteochondrosis. You are able to see that the tissues of the disc start invading into the bone, and the tissues of the bone start invading into the disc. So due to chronic inflammation, the delineation between the two tissues is totally lost, and it becomes a total structural problem which is called as osteochondrosis. That is fatty degeneration of the marrow. The bone marrow content is reduced. There is fibrosis and hyperemia of the marrow. So it is replaced, as you know, any tissue that is damaged in the body gets replaced by fibrous tissue. So fibrous tissue goes and deposits there, and then there is more blood circulation, and finally it produces sclerosis of the vertebral end plates. So the entire vertebral structure is gone, and this is a bony sort of a structure which cannot be expected to withdraw. What is happening? We have to clearly delineate between a herniated disc and an osteochondrosis. If it is a herniated disc, there is always a chance of that coming back. As long as the pressure is removed and you keep it like that for some time, the natural tendency is for the herniated nucleus pulposus to come back. It can get retracted into its original position and the patient can become normal as before. Whereas if it is a bony tissue which is getting compressed, which is getting expressed, and it reduces the spinal canal, then there is no chance of this suddenly going back with treatment also. What relief we find in these sort of patients is actually the relief that is happening because of healing of the nerve. The demyelination that is taking place in the nerve is what produces the symptoms. And I think, and I cannot give you a definite reply, but I think that the symptomatic relief that we are able to see in demyelination happening due to radiculopathy or myelopathy is actually due to the healing of the demyelination. We are able to remyelinate the nerve probably, and that is why patients are improving. We cannot really expect that the osteochondrosis, that is the bony protrusion, is actually getting resolved. I don't know, I'm still guessing. We should probably look at it so deeply and try to document what is happening there. If we are able to come up with a concept that we can even get into resorption of this bone, then I think that's the ultimate. We will have sort of been on top, really, top of the world. Now we come to the key diagnostic points. Generally, to look at cervical spondylosis, who are the type of people who come to us, it's a middle-aged person, predominantly males. Males have got a higher ratio of cervical spondylosis than females, and the usual complaints are pain, tingling sensation, numbness, even pinprick sensation manifested along the irritated root, more at night. So that is a typical manifestation. In the upper root afflictions, that is, if you see C2, C3, etc., their patients can complain with tinnitus, that is the ringing sound in the ear. Patient can complain with giddiness, occipital headache, or transitory fainting. They can also have sudden episodes of fainting as a manifestation of cervical spondylosis. Whereas in acute irritation, patients present with keeping his hand over the head of the affected side. They will generally tend to hold it like that. It is very severe. They can also present like that. Relief in pain by lying down and resting. Generally, when they lie down, that is when the pressure, the vertical pressure on the disc is relieved, there is some level of comfort. Sometimes, if the lordosis of the neck is lost and the neck, this portion is not supported, they can also be uncomfortable lying down, because basically the cervical vertebra there has got a curvature, and if the curvature is not supported adequately, see, very often, though that is part of the treatment aspect, I would like to mention some of my observations there. Very often we all tend to advise patients not to use a pillow. Cervical spondylosis patients are generally advised not to use a pillow, but in my opinion it is wrong. Because there are a number of patients who don't lie on their back. They invariably lie on their side. And patients who lie on their side, if they don't use a pillow, their neck is hanging like this all the time. They are in acute lateral flexion. And if it is in that situation, they can definitely aggravate their neck. If they are lying on their back, it is a good idea not to use a pillow, but even then it is advisable to use a towel rolled and kept at the neck. So there are now specialized pillows called cervical pillows which protect the curvature of the neck. That is one of the best ways to handle the physical problem there. So relief of pain while lying down is a general feature if the lying down is proper. If the lying down is not proper, that itself can lead to aggravation of the pain. The aggravating factors are strained walking, overactivity, jerky drive, humid weather, etc. So all these different conditions tend to aggravate the presentation. There is restricted movement of the cervical spine. Invariably, a patient with cervical spondylosis, you can understand before he comes in, because he would have held his neck very rigid. He will not tend to move his neck very easily. But that is the most easily relievable symptom of cervical spondylosis. Cervical compression test usually positive. If you test for this, you ask the patient to have a flexion and extension. You must ask him to have lateral rotation, lateral flexion on both sides. If these three generally don't produce any aggravation of pain or rigidity, both active and passive we need to see. And that is the most important physical test that we try to elicit in a patient. After that we come to the DTRs and so on. So cervical compression tests are usually positive. There is paresthesia in the periscapular region, deltoid region of the fingers. There could be lack of sensation in the scapular region, in the deltoid and so on. Local tenderness in the cervical region in acute and subacute manifestations. If you try to palpate the local tissue, there will be pain or tenderness in that particular region. Rarely there is reduction in motor power in the hand. Patient in whom the motor nerve roots are compressed very severely can have problem with movement also. X-ray, especially lateral and oblique views, are the most important things to be taken to ascertain a bony lesion, whereas a mild disc related problem may not often get manifested in an X-ray, because we are not seeing the soft tissue clearly, we will only see the bone clearly in an X-ray. You need to go in for an MRI ideally to clinch the diagnosis of cervical spondylosis if you want it. But very often a clinical diagnosis is more than enough for us to diagnose the condition and go ahead. Congenial malformations may be a confusing factor. One of the things which I forgot to mention to you in the anatomical consideration is, I mentioned about the bones and the intervertebral disc. There is another tissue which is equally important, which is the ligaments. There are the ligaments holding these vertebrae together. There is the anterior ligament, the posterior longitudinal ligament and so on. So many ligaments are holding these vertebrae together. If these ligaments become thicker with age, they are called as hypertrophy of the ligament. That can also produce compression on the cervical spine or the nerve roots, etc. That is also to be looked into. Very often the ligamental hypertrophy is also a cause of these symptoms. Now we come to the typical clinical presentation of pain, sensory loss, reflex loss and motor deficit associated with the different levels of cervical spondylosis. If the C2, C3 vertebrae are affected, we find there is pain at the back of the head and lateral side of the face and behind the ear. That is the area that is innervated by the C2, C3 nerve. Sensory loss in the posterior scalp, in the pinna and in the lateral aspect of the face, and there is no reflex loss because this area you don't have deep tendon reflexes to elicit. There is also no motor deficit because it is fundamentally not innervating any of the motor muscles. Then the major prevalence comes from the C5 to C7 region. C8, there is no C8 vertebra but there are C8 nerves. The nerve that is emerging below the C7 vertebra is called the C8 cervical nerve 8. So you should not get confused. There are only C7 vertebrae but C8 nerves are there. So C5 nerve, if it is compressed or affected, it produces pain in the medial scapular region and the lateral side of the arm. There is sensory loss in the lateral side of the upper arm and the biceps tendon reflexes. Biceps tendon reflexes are reduced in radiculopathy. The deltoid, supraspinatus, infraspinatus and rhomboids muscles could have motor deficit. And in the case of C6, we find the lateral forearm, the thumb and the index finger, this distribution is, you suffer from pain or there is sensory loss in the lateral forearm and in the thumb. The supinator reflexes are affected. The supinator, we check the reflexes here and that reflex is diminished in the case of a C6 lesion and the triceps reflex is diminished in the case of a C7 lesion. The C8 lesion basically affects the finger stretch reflex. You stretch the finger and do the finger stretch reflex. That is getting reduced in the case of a C8 lesion. Whereas pain happens in the medial forearm of the hand, the medial aspect of the forearm and the little finger suffers from sensory loss and the finger stretch reflex is diminished. So basically these clinical examinations features itself would clinch the diagnosis of cervical spondylosis in most cases. So it looks that it is apparently a very easy problem for us to diagnose. So the real challenge for the primary care specialist is to be able to recognize the more serious disorders that require early referral. There are a number of other serious diseases which could mimic cervical spondylosis. And even in cervical spondylosis, the condition that requires probably a surgical correction, and most of the other conditions which do not need any sort of more serious intervention should be conservatively managed. So additionally, it is important to have the confidence to institute specific treatment for non-urgent conditions in order to avoid unnecessary referral of patients with generally limiting conditions. So I think that is the crux of the matter why this whole session has to be dedicated, because we must know what we are supposed to treat and what we are not supposed to treat. Most of the conditions are treatable. There is a lot of literature available that most, a very large percentage of the patients can be treated conservatively with equal benefit as that is derived from even a surgical decompression. But still there is that small percentage of persons who definitely benefit from a surgical intervention. So knowing that is one of the cruxes of the matter. And then there are several other conditions which could confuse us between cervical spondylosis. So the differential diagnosis becomes another very important aspect. The common diseases that we need to, I wouldn't say all of them are common, but then the diseases that we need to be very careful about are listed below. One common situation that we see producing pain in the shoulder and also radiating to the hands